A very good evening to you and thank you for joining us on Health and Wellness. My name is Zaitun Ali and today we're coming to you from the KTN Hospital. The topic of discussion is about occupational therapy. Normally it's being associated with children living with autism, but today we are going to delve deeper into that topic in general. With me, I have Dr. Nyacheo, who is an occupational therapist right here at KTN Hospital. Karibu sana.
Thank you so much.
I'd like you to talk to us about what is occupational therapy.
Thank you so much. First of all, my name, as you heard, is Nyacheo. I head the Department of Occupational Therapy at the KTN Hospital. I have 13 years of practice experience as an occupational therapist. Occupational therapy is an art and science, which I will explain to you what is the art and what is the science of it, which deals with occupational challenges in society. Any condition which either will impair you from functioning or is limiting you from functioning, it's an occupational therapy condition. So occupational therapy, we can say, is divided into three major areas. When we have in pediatrics, that's what we mentioned about children. So we have children who have developmental challenges, either through birth or through their genetic conditions like autism, cerebral palsy, Down syndrome, and ADHD. ADHD is attention deficit hyperactive disorders. So these children are not able to function normally in their occupations, and the occupation of a child is play and schooling. So that's why those conditions end up being an occupational therapy conditions. So when we go to adults, we have adults with very many physical dysfunctions. You get a traumatic brain injury, you get a stroke, you get a fracture, or you get an hand injury, you're not able to function normally because of the functional components which are affected. Either it's the range of motion, is the muscle strength, or is the cognitive aspect, then that becomes an occupational therapy client. Then we have a very major area of mental health. Occupational therapy started from mental health, and mental health is not well understood in this country. So occupational therapy in mental health is very key because we assess these individuals who have very many conditions under the mental health spectrum. And then when we assess, we see how to restore them, either it is their cognitive aspect, either it's their social skills aspect, either it's their self-esteem or their productivity in general. So they become occupational therapy clients. So in that way, whether you have a condition like schizophrenia, you have those who have psychosis induced by alcohol or alcohol withdrawal syndrome, and we've seen a lot of mental health cases now coming up. So all these end up being occupational therapy clients, and that's why we say occupation, because we look at it in three aspects: in terms of work, in terms of leisure, in terms of your daily living, the activities of daily living, whether you are able to dress normally, toileting, feeding, generally managing yourself. Those are the activities of daily living. Then in terms of work, of course, the productivity aspect, and that's why when I tell about children, their occupation is schooling and play. And then in terms of leisure, leisure is a very important occupational pursuit. And we say occupational therapy is very key because human beings are occupational in nature. Yeah.
Daktari, what you've said is very comprehensive and very wide indeed. As we now start to narrow it down, let's talk about occupational therapy, especially in the community level, where work is entailed and also leisure. So let's talk about it in depth.
Occupational therapy is very much in the community, and in developed countries, occupations are practiced in the community. Because why are we focusing in the community? The barriers of maybe, for example, persons living with disability usually is in the community, either the terrain of the environment, the structure, and all other aspects of the community and the society. Those pursuits are the ones limiting the patients from practicing their daily challenges which come along with that. So when we talk about in the community, first of all, it's educating the community, because we are dealing with disabilities. And many people have very many myths about various disabilities. So community education is very key, and community mobilization is very key aspect of occupational therapy. And then empowerment, because persons with disability, more often than not, end up getting so many challenges, either in the education, in the work, and in general in the society. So bringing them together to form an income generating activity, empowerment groups and support groups in the community, it's very key. That's where the challenges start and end up. Like now, the disabilities, more often than not, people have a lot of myths about what causes the disabilities and what how can the intervention be done. So that's why it is part of the community and the primary healthcare component of our society.
Okay.
Yeah.
So as you're talking about occupational therapy, what does it entail? What activities do you do?
Occupational therapy, we use occupations in intervention. So we assess the client as an individual, never one structured intervention amount. So once a patient comes or is referred or we identify the patient for occupational therapy, we do what we call occupational analysis. We see what are the strengths of this patient and what are the limitations in this patient, so that you are able to perform your daily living activities normally. For example, if it's the range of motion, you got a fracture, which is an occupational performance component, the range of motion, if the joint is able to move, the hand are able to function. So the interventions are really customized depending on the occupational needs of that patient. So then the interventions could be adaptation of the tools, adaptation of the environment, could be changing the method of doing it, or changing the position of doing it, or enabling this patient to develop the limitation they have, so that they are able to perform the various activities, whether it's a mental health patient, whether it's a physical dysfunction patient, or whether it's a child. So the interventions are really guided on the specific presentations of the patient. Yeah.
And especially on mental health, what role does occupational therapy play?
Occupational therapy is very important in mental health. One, the people with mental health challenges, some of them do not have insight. Lack of insight is when you are not aware that you have this challenge. So instilling insight in that patient through occupations and through engagement. Then through occupations and through group therapy, you are able to assess the performance of the client in relation to others, the motivation and the abilities of doing that activity in terms of what skills is that patient needed, so that they'll be able to be productive and be independent in society. So basically, once we assess because mental health is quite a wide area.
Yeah.
So once we assess the patients, we get what we call occupational performance limitations. So once we get the limitations, now we draw our intervention plan based on those needs to enable the patient to get to a more productive and a more normal functioning level.
A common need under mental health that you normally deal with is
like
what, for example?
Self-esteem, denial, lack of insight, lack of appreciation that you are sick, and then the aspect I said of the society in terms of people with a mental health condition. For example, I tell you like schizophrenia.
Okay.
Schizophrenia is one of the major common conditions in the mental health perspective.
Which means?
Schizophrenia is you get a client who is a stereotype in the behavior. Of course, it also depends which type of schizophrenia. They are withdrawn from the society, they are in denial, or they have delusions, for example. Delusions are false fixed beliefs. So through participation in activities, they are able to explore their self-image and their self-status to be able to get insight that now this is usually a false fixed belief, it's never the reality. So reality testing, we use very many standardized tests to get to specific needs of that patient. Then now we draw the intervention plan from there.
Okay.
Yes.
And what about children?
Like you mentioned, occupational therapy is commonly associated with only children.
Yeah.
On children, we start from at birth. It's what we call neonatal occupational therapy. There are those children who are what we call high-risk children. Children who do not cry at birth, they are underweight, they are prematures, or they have some main complication at delivery. They become under what we call early intervention and early monitoring levels in terms of developmental milestones. Either the reflexes will tell us now this kind of client needs to be monitored for early intervention. Then we have conditions in children like cerebral palsy, which is very common, which is brain damage either pre, during, or post delivery. So occupational therapy focuses on developmental milestones in that children, cerebral palsy. Then you have cases like Erb's palsy. Erb's palsy are injuries at birth, which occur maybe when there is prolonged labor. So some deformities develop. We intervene on those deformities. We focus on the concept of plasticity of the brain. Plasticity of the brain means the younger the brain, the more likely it is to learn new skills. So our interventions in that pediatric is based on that. Then we have autism, which is now the burden is all over, and this is the autism month, which as you know.
Yes.
Autism become very common because you see the presentation of autism, the communication challenges, behavioral challenges, and some behaviors which are deviating from the normal. So occupational therapy, using the approach we call sensory integration therapy,
Okay.
designs program to help these clients to be near normal or more normal, depending on the level of the autism itself. Then many other conditions like Down syndrome, they're still part of occupational therapy in pediatrics.
Yeah.
We have children who get developmental delay with no known cause. They still come for occupational therapy.
Or just out of the blues.
Yeah, developmental delay,
Yeah.
global developmental delay without any other underlying condition.
Okay.
So they end up being occupational therapy clients.
Okay,
Yeah.
that makes sense.
Yes.
And as we're talking about occupational therapy,
Yeah.
to be precise, especially in children, how do they now respond to it, respond to these activities? What role does it play in their developmental?
Therapy is very key to their development. Of
Yeah.
course, how they respond is individualized because it depends, one, on the level of the condition, two, on the quality of the intervention, three, on even the adherence, because when it comes to matters disability,
Yeah.
it's usually a team approach. Yes, the occupational therapist, I will do what I can, but there's a program for the parent, a program for the school, a program for any caregiver who stays around with the child, or any other players, like any other medical team, the pediatricians, neurological specialists, neurodevelopmental specialists. So the response is really team approach, but as occupational therapist with consistency. I mentioned to you the issue of plasticity of the brain.
Yes.
So the younger the brain and the consistency in terms of the intervention, these kids get to acquire the milestones. I've seen kids, I've told you I've been a therapist for 13 years. I've seen kids who have done an intervention and we have discharged them. They have acquired the necessary milestones, then we discharge them. There are those who we put on milestones monitoring, and then we reach a level, you find they have achieved all what you wanted, then you discharge.
Yeah.
Of course, there are those who, depending, like if it's autism level 3, which is the extreme level, sometimes they are able to acquire basic skills which will enable them to be a bit independent and functional in society as much as can. So the effect is as good as I'm mentioning it, but it's on individualized kind of cases.
But a disclaimer, it does not like heal.
Yeah.
It does not totally heal the.
It depends on the condition. For example,
can heal.
when we are talking of conditions like I've said Erb's palsy,
Okay.
you have seen kids born the hand twisted like this, usually because of the position when during delivery. Those ones we cure completely through splinting and through therapy. We are able to achieve all of that. Then we have what we call crab foot. We have seen kids born the legs like that.
Yeah.
Then it's curable there. We have kids, as much as we're talking about this time, we have rickets in society right now because of the nutrition aspect. Rickets, when done occupational therapy in early intervention, there is always good outcome. I've seen cerebral palsy as I mentioned, as an occupational therapy. My aim is to enable these clients to be independent and functional as much as possible.
Yeah.
I've seen so many cases of cerebral palsy, of course, depending which type of cerebral palsy, which have developed until they're functional normally. I've seen autism, which they have done intervention and they're functioning normally and productive in society. So, yeah, the outcomes are as good as I'm saying.
Okay.
Yes.
There's a difference between now physiotherapy and occupational therapy. Now,
Yes.
what's the difference?
Yes, there is a difference. You know me, I will speak more about what an occupational therapist is, but generally, there is a difference between physiotherapy and occupational therapy. We are in this hospital, we are in one department, the Department of Physical Medicine, where we have physiotherapy and occupational therapy. But occupational therapy, as I mentioned, they will focus on function in terms of work, leisure, and activities of daily living. Conditions which are affecting the patient from being independent in that. That's why the name occupational. For physiotherapy, of course, even the modalities they use is a bit different. You'll find like they use the gym area there and the hydrocollector for the hot packs and some nerve stimulation. Yes, they focus on some aspects of function, like strength, endurance, and balance. But mine is so finer into that because now, like in school, for example, an occupational therapy will focus on this child to be able to have even the fine motor skills, the grasp patterns, and even handwriting skills. So while the physical therapist will focus on the physical aspect of that patient.
Okay.
But I don't speak much about the physiotherapists because they know better what they do.
True.
Yes.
Talking about occupational therapy in the workplace, how does this work?
In the workplace, occupational therapy. I know we have occupation. There is a whole directorate in this country called Occupational Health and Safety.
Yeah.
But we have workplace injuries. One of the roles of an occupational therapy is one to assess the impact of those workplace injuries. Many people around are not able to ascertain, yes, you got a workplace injury. To what extent did it affect you in terms of function? But us, we are able to determine that, like this, you got an elbow injury or you got a wrist injury, and this is the extent of damage it caused on you, and this is the extent of dependence or the limitations you have.
Yeah.
So workplace injuries, of course, training workers on best workplace practices, even ergonomics. Our ergonomics is the posture at the workplace.
Oh.
So yeah, we'll teach you on workplace postures and workplace safety, and also teach you about the impact of those injuries and the prevention part of the workplace injuries. Then workplace habits and routines, which will enable you to be functional. So we have right now, we have the Ministry of Health has rolled out a tool, which is disability medical assessment and categorization guideline. So that tool, many people are not aware about it. So even when you get, for example, you have a finger injury, we are able to tell you what percentage of functional roles you have and what percentage of, if it's compensation, what percentage of compensation you need to be given. Many people in the health sector try to guess around, like this one has got 60% based on no specific tool. But right now, an occupational therapy will use a specific tool to assess you in terms of function and dependence you have, then give you the right kind of justification.
And as you're training on perhaps posture, especially in the workplace, for the adults, as an occupational therapist, what do you advise? The long sitting hours,
Yes, we have what we call office ergonomics. Office ergonomics, These are the postures, the workplace routines, where the level of the desk, the brightness of the computer, where even the angle, even the sitting angle and the position of various tasks depending on what you are doing in that day. So that is the role of occupational therapy. In developed countries, that is a very big area of practice. In this country, I can tell you it's something coming up. In industrial and the work office economics, so we teach you about the routines, the tools you are using, the routines at the workplace, the hours you are supposed to sit, the sitting angle, the viewing angle, even the computer. You see most people use a laptop now in the office, and you see many people using the phones. You find the position you are assuming will get subject you to some what we call a cumulative trauma injury. So we teach you to prevent those injuries.
Give the audiences and the viewers a tip on how best to position yourself when you're working on a laptop or when you're working on your phone.
When you're working on a laptop, you sit on this kind of posture, in an erect posture. Then the laptop, the viewing angle should be not leaning and not too high. So you are just viewing like this. Then the seat must be in a position you should be able to rotate, because if you are checking some cabinets or you are printing something, there must be some
the one you're sitting
on. You must be able to move around. Then the foot must have a footrest, or you must be able to sit on the ground like this. Then the angle, the elbow must, the working surface, that is the table, you must not be able to position your elbows like this or this way. So it should be this angle, this level, the elbow level. Then now what I'll talk about is the distance. It should not be too far, not too close, because it also has got challenges with our visual skills. So that is just a demonstration of a typical office layout.
And the brightness of
the brightness, yeah, you've seen
machine.
now computers. Of course, now that is for the ophthalmologist.
Okay.
But I've seen laptops and computers have that gray screen to prevent the visual challenges. Because when you're looking at workplace injuries, you look at it all around, even the writing system, the ventilation, the safety, if you have the cables and all that, all of them, they contribute to workplace injuries. So we look at all of it as a whole.
Okay.
Yes.
And being also the month of Stress Awareness Month,
Yes.
I know as an occupational therapist, you've gotten such kinds of complaints from people suffering from stress, and how can you now help them? It's part of mental health as well.
It's very true. But in the bigger picture,
Yes.
if you understand any condition, occupational therapists, we are disability managers. We deal with the levels of disability in so many aspects.
Yeah.
So one of the challenges in disability is the acceptance. Actually, you have a patient, you have a child, and you are told this child is autistic. This child has Down syndrome. You've got this patient that's got a spinal cord injury. Now you see there are stages of the disability acceptance. It's the biggest level of challenge we handle is now the parents. Like here we have a parent support group. Right now there is the autism is really, the burden is all over.
Why is it the case?
I'll come there.
Okay.
The autism is really all over. So one of the first stages is to establish and maintain rapport with that patient, and then we have a support group of mothers or fathers or parents who have these kind of conditions. So that is one way they support themselves, they share experiences, do group activities, and do what we call group sessions, monthly support groups, so they are able to accept that they are not the cause, because some of the people don't really accept the conditions as such. Number two, how to handle it, where to go for school, because some schools are not available, which medical cover to get, which hospital to come for intervention, and all that. So the group is so much. Occupational therapy, we do what we call psychosocial support for those kind of clients. Lastly, coming to your question about autism, the cause of autism is unknown, but we have what we call risk factors. And there is genetic factors, there is environmental factors, but there is, for now, the context is there is a study which has been done to explain that exposure to too much of the screen for a child who is below 3 years for more than 4 hours a day is causing what we call virtual autism. Virtual autism, those they use gadgets, they have laptop, tablets, phones the whole day. So they are more likely to be predisposed to social emotional deprivation, which is a very important indicator in autism. Then we have, of course, the awareness campaigns have gone high, so many doctors are able to identify it. Literally, in the initial days, it could have been missed, but now, because many doctors are able to identify, they are able to pick the autism. Then we have advancement of the diagnostic tools. We usually have a tool called the DSM-5 now, Diagnostic Statistics Manual, the 5th edition. The 5th edition has expounded on the diagnostic considerations to include level 1 and what we call classical autism, which was never there in DSM-4. So the wider the net, the more it's likely to cast more. Then we have, of course, lifestyle. You see parents and everybody else is pursuing career. You find you are getting your firstborn when you are 43 years old. Anything to do with disability, the more advanced the age of the parents is, the more likely it is. I'm not saying everybody, but the probability.
Most of them.
Yeah, because of all those challenges. Yes.
Okay. Yeah. Thank you so much for the insights that you've given to us. And perhaps after the break, I know we are coming back with more about occupational therapy. We are still right here with Dr. Mark, so don't touch that dial. We're taking a short commercial break. This is Health and Wellness. Welcome back to the show. If you're just joining us, remember this is health and wellness, and the topic of discussion has been occupational therapy. My name is Zaitun Ali, and I'm still joined by Dr. Mark, and right here we are at an occupational therapist treatment center. So you can see how involving, how many activities there are here, and Doc, you'll take us through. Karibu sana.
Thank you. So as we mentioned, we do hand rehabilitation therapy and cognitive therapy. So with us here, for example, when a client is doing this activity, there is that eye-hand coordination skill we are training in, for example, a child. Then we're talking about concentration. Then we are talking about problem-solving skills. All those is able to figure out which nut goes to which hole, because they are not different. They are different sizes and different holes. So yeah, you can see they're small, medium, and large. So the problem solving, the judgment, the concentration, the eye-hand coordination skills, and the ability to sit and do this activity, and also task completion is a skill, so which we prepare these clients in doing that. So basically, this is also a sitting aid, which is an equipment of intervention for postural correction. So assuming that the client is not able to sit, we are teaching them to sit at the same time, doing activities to achieve those skills. So that is what happens on a typical session, like what is doing. They can do a number of activities while there.
Oh, that one looks colorful.
Yes. So we are talking about another skill, for instance, the eye-hand coordination, color identification, matching skills, and puzzle fitting skills. All those are the prerequisite skills required in occupational therapy and occupational performance. So when you give a child to do this, it might look simple to you, but for them to arrange this, to identify which one comes after which one, it's a very important skill in pediatric occupational therapy. Yeah. The next here, we have all these table activities. The table activities, so you can be my client.
Let me sit down.
Yes. The table activities, for example. We encourage you now to do eye-hand coordination skill and the grasp patterns. So you are able to remove this, put them aside.
All of them?
Yeah. And then you do them back when you see. So? Training on concentration, following instruction, matching skills, and motor skills, which are prerequisite in terms of, for example, school preparation. When we are talking of grasp and prehension patterns, so those are the fine motor skills which are prerequisites and lacking in these children who have developmental challenges, even adults who have a condition like a stroke. To be able to have that coordination to pick and return and put it back requires a lot of coordination, eye-hand coordination, dexterity, and that fine motor grasp skill. The same thing with this, same thing like this. Be able to move it up.
Oh my God,
Yes. So you see that judgment, coordination, problem-solving skills in that client, it enables us to achieve that skill. I told you we use activities which are analyzed because they have properties which require. Yes. So getting it back, you have to figure out how to get it back up to and down there. So we do activity analysis and see the task demands of doing this activity, and then the deficits of that patient. We are able now to design this program for the client to be able to achieve that skills. The same with that. Now you take.
Does it come with this one?
This comes with this. With this one. So this one you take it up to the hand here.
This is hard.
You figure out. So that concentration, problem solving, the activity to maintain eye contact, that is the concept we want to achieve in occupational therapy. Then you see there are different shapes. We are holding this. These are called a tripod prehension pattern. Then there is this when you are holding with two hands called fingertip prehension pattern. Then there is what we call, like when you open the door or when you are starting a car, that is called lateral prehension patterns, which we train the clients to have those hand skills for them to be able to be independent in functioning.
Wow. So they're not supposed to be like the same color going through?
It's just a figure which is designed. There are many designs which can come with this to achieve various activities and various functions.
Okay. So this one helps in concentration as
concentration,
well.
eye-hand coordination, and for grasp patterns and fine motor skills. Okay. So this is the vestibular hammock swing. This is part of what I explained to you called sensory integration for those kids who have ADHD, which is attention deficit hyperactivity, and autism. So one of the presentation is the energy level, which is high. This is vestibular. It's used to calm them down. So whenever we do this is sensory integration therapy. In 15 to 20 minutes, she will really calm down. So when you see a child who is very hyper, or has also avoidance of heights, what they call gravitational insecurity, we do a lot of this, and this comes with many components. That is the seat with the net. There is the flat one there, and there is the tumble from there, which is vertical, but it achieves the same thing. So vestibular stimulation to calm down, and it has a very calming and soothing effect. Within 2 minutes you will see that.
In case I sleep, nifungie show.
Yes. So that is what, and that's why it's called vestibular, the 2. So this one, there are like 3 in this country, this equipment. Yes. And you see there is a safety measure. This is very measured. We cannot really have a challenge in safety of the clients. Then you can see the mats and how it's padded. In the unlikely event we have any fall, we have this kind of measures.
Okay.
Yes.
When it comes to now kgs, am I too heavy?
No, you are not too heavy. This equipment is meant for vestibular stimulation of all people, and the maximum given on this equipment is 110 kg. Of course, whoever who is, you look like you're 60, so you are very safe. Usually also, for those who have, for example, gravitational insecurity, seeing yourself, there's what we call mirror box therapy. So there is usually a mirror here. You see yourself swinging in space. You have body position challenges in space. You will see yourself. So I've seen when kids, they see themselves with repetition, they're able now to develop that sense, and in their daily life, they'll find that it's like normal to walk in space, they don't fear any heights. That is now the vestibular aspect of the stimulation of this. So it we have a pool of balls. So this one is used for various sensory needs. The first one is a sensory break. When those kids come and they are irritable or they are not able to stay in other place for a long time, usually we put them here. It's like a sensory break for them. They relax. There is a soothing effect here. Number 2, it's also used to do what we call tactile stimulation. One of the challenges of those conditions I've explained to you, autism, is tactile, the sense of touch. To them, they are either sensitive so much, even to dressing and clothing, even to haircuts. So when you put them here, you see they are getting that feeling all around. It's giving that effect. Also in training what we call visual motor skills. Visual motor skills in skill like identifying the yellow ones. You tell them, give me the yellow. It's able to pick yellow from the many of these balls. So those are figure ground skills. So the pool also plays important skills in turn taking. You explain to this child to throw out the balls and give another one. So the challenges in their social skills, turn taking, task completion, you can give them this kind of activity they do, and with repetition you will find at home or at school they start learning the skills of repetition. Also, task completion, as I've explained to you, is very important for a child to be able to begin an activity and complete. So when I give them maybe 10 balls here, and then you pick them, you return them. That ability is called motor apraxia of movement. It's really achieved with this kind of challenge. That is basically the basics of occupational therapy.
That is a lot.
It's wide in other areas, but that's what we can explain to you here at the KTN Hospital.
That's a lot, and we've learned also a lot. Ona venye amefurahia How you feeling uko ndani? Unasikia poa? Okay, thank you so much, Dr. Mark, for everything that you've taught us about occupational therapy.
Yes.
And as we're marking also Autism Awareness Month,
Yeah.
this one is for you. In case you need these services, where can they find you?
So, as we are marking the World Autism Day and World Autism Month, at the KTN Hospital, we do provide these comprehensive services, both the occupational therapy and speech and language therapy on a daily basis and on a 24 hours service in our main hospital. And in our branch, which we have a child development center in Nyeri, where we offer these services under one roof: physiotherapy, occupational therapy, educational assessment, nutritional assessment, and speech and language therapy at a very competitive rate. Thank you so much.
Asante sana. Thank you also, dear viewer, for staying tuned from the beginning until the end. This has been Health and Wellness. In case you missed this episode, find it on YouTube at KTN Home. Also on our socials at KTN Home _ on X and on Instagram, and at Ali _ Zaitun. Until next time, see ya.